I want to start with introducing you. So Terry, can you tell us a little bit about, you are the owner of SleepWerx and you've been in sleep medicine for quite some time. Can you tell us a little bit about your credentials and your background?
Yeah, I started out in nursing in the mid 70s, right around when DIRT was invented, and actually even spent part of my nursing training working with people with polio and iron lungs and rocking beds back in those days. When I moved to, I was born and raised in Canada, and that's where I trained originally. But when I moved to America in 1982, I started going back to school about 1984 or so, and finished my master's degree in 1991. I spent a few years as clinical nurse specialist for 144 medical and surgical beds with the operating room as a stepchild. And then when I finished my acute care nurse practitioner and adult nurse practitioner, I joined a hospitalist group for a short time. And then I joined a neurosurgeon. And after that, physical medicine and rehab, where there were quite a bit of traumatic brain injuries kind of patients, and stayed in neuro and neurology and sleep medicine for the last several years.
What is it about sleep medicine that really draws you and made you want to land there?
Everybody's different, for one thing. Everybody responds to sleep disorders differently. And it's always interesting to me how a person does respond to their disorder and their treatment. And number two, people get better. After years in healthcare, I really like seeing somebody get better and feel better. And some of the treatments for sleep disorders are absolutely life-changing.
Absolutely. I agree with that 100%. We're going to start with your slide presentation, which I just love that you put together for us today. And then afterwards, we're going to ask some questions. I know I have some questions for you. And one of the big ones that I have for you is about palliative care, because we just don't hear a lot of providers talking about it. And I kind of want to have you help tie in how palliative care can help with somebody who does have a sleep disorder and is treating a chronic illness. So, but let's get started with your slide. I'm going to share the screen.
Okay.
Okay. Can you see that, Terry?
Yep.
Okay.
Yep.
All right. So I'm going to let you just kind of lead the way, and I'm going to advance the slides for you as we go. Okay.
Yep. Ready for the next one. Similarities with chronic illness and living in a pandemic, I wanted to start with, because what are we really talking about with chronic illnesses? In terms of palliative care and or hospice care, they're quite different. And so I wanted to just touch on the stark similarities between living with chronic illness and living in a pandemic. It does push the pause button on life as we know it, and we have to make several adjustments with chronic disease, as we do in a pandemic, and we have to take precautions with people. In some cases, it may be fall precautions, and in other people, it may be seizure precautions, and in some people, it's protection. We get tortured. I think people get tortured with chronic illness. The symptoms are absolutely relentless. They never stop. They never get better. They know they're never going to get better, and is this as good as it gets? How can I make it better if this is as good as it gets? There's got to be a way to get better, but there isn't. People have good and bad days, and I think one of the big things with bad days is with the isolation and loneliness that people feel, and that starts to wear on your self-image and how you present yourself. You're not around enough people anymore. You tend to sequester yourself in a room off by yourself. It starts to bother you to hear a lot of noise around you. And I think about chronic care, say for people with glioblastoma, brain cancer, they start to lose the attentive focus in a conversation, and it gets overwhelming, and so they pull away from their family and friends as well. Plans for the future, it's not the same anymore when you plan for retirement and a cruise around the world, to find that you have a disabling illness or your spouse has a disabling illness. And no matter what kind of treatment a person gets, the symptoms carry on. You start to feel helpless. You have no control over the situation any longer, and you have to be able to give up that control that you think you have in order to be successful at living with a chronic illness. And fear of the unknown, I think, is probably one of the big ones. What's going to happen? How will I cope?
Yeah, absolutely.
One of the talks I prepared earlier was strictly dementia and Alzheimer's disease, but today in talking about chronic illness, I wanted to include heart disease. A lot of people live with congestive heart failure. A lot of people live with coronary artery disease, although I didn't spend too much time on coronary artery disease. It's not as closely related with sleep apnea as heart failure is. COPD is another chronic illness that is heavily tied with sleep disorders. And of course, cancer. People with cancer have a lot of problems sleeping. It tends to be more of the insomnias than the apneas. And people with chronic pain, the same. Can't go to sleep because you're hurt. You can't stay asleep because you're hurt. You can't turn over. Now it's woken you because you've turned over. All of these are debilitating conditions to live with, in my opinion.
I agree. Terry, can you define COPD for those of us that may not be familiar with that acronym?
Yeah, chronic obstructive pulmonary disease
And
is what that stands for. And it entails things like emphysema and bronchitis. It's not an easy disease to live with, for sure.
Asthma, yeah, that's a tough one.
Yeah. How many hours of sleep do I need? This is always an interesting question. Some people, although the healthy adult needs between 7 and 9 hours of sleep, there are some people that need 10. They can't function without 9 or 10 hours of sleep. And then there's a select group of the population that needs 5 or 6 and they're fine and they absolutely do function. Not everybody can do that. And not everybody can function on 10 or 11 hours of sleep either, but there are some adults who do need longer sleep times and there are some that need shorter sleep time, but that middle of the bell curve is 7 to 9 hours. People over 65 should try to get 7 to 8 hours of sleep, but as we all know, quality of sleep deteriorates as we age. We're not going to stay asleep all night, and it's not just because you have to get up to use the washroom. Sleep is interrupted as we age. That's just a fact of life, unfortunately. Older people tend to get less of the deep sleep, and that's the sleep that helps keep the brain healthy and refreshed. Those frequent awakenings are really annoying as people get into their 50s and 60s. That starts to happen, and people become annoyed with that. I used to sleep through the night, and now I can't sleep through the night if my life depended on it. I'm tired when I wake up, and sometimes they are tired when they wake up. But for the most part, as we age, a lot of things change, and sleep is one of them, and it's just something we have to live with.
And Terry, when you're talking about that slow wave sleep, is that the REM that you're talking about?
REM sleep's different than the slow wave sleep. REM sleep is where we dream and the brain does some housekeeping and categorizing. Slow wave sleep is deep sleep, stage 3 sleep, and at the end of stage 2 towards stage 3.
Okay.
Stage 1 sleep is just feeling groggy. The example I like to use is if you're watching a TV show and you start doing the woodpeckering with your head and someone changes the channel and you say, don't change the channel, I was watching that. That's stage 1 sleep, where you're sort of awake and sort of asleep.
Okay. And so in that deep sleep versus REM sleep, what are the benefits of the two? What are the differences between the two?
Deep sleep is restorative to your body, where your muscles are repairing, your cells are repairing. And the REM sleep is where your brain is actually doing something to care for itself.
Wonderful. Thank you. I like that.
I love this picture. Yeah, and aging is inevitable, but when you age without sleep, it's torture. Does sleep quality matter in dementia? Does longer sleep equal better sleep quality? The first question, does it matter in dementia? Yes, it does. Does longer sleep equal better sleep quality? No, it doesn't. Part of the theories with dementia is that parts of the brain are damaged, and some of those parts that control sleep and wake may be damaged in neurological illnesses like Parkinson's disease. People with Parkinson's disease have terrible sleep. It's okay when they start out with Parkinson's disease, they can sleep, but as they get further in their disease, sleep becomes horrible. They have a lot of wake ups, they have a lot of acting out dreams and being physical during their sleep. And that makes you really tired during the daytime, and they can't seem to catch up. And it causes a lot of agitation as well. Alterations in biological clock. Again, some people need more sleep than others. And interestingly, sleep before acquiring a chronic disease has influence on how you sleep with a chronic disease. And we'll talk about more of that later. Light exposure is another thing. There's a lot of studies coming out of U of A psychiatry sleep program actually about light exposure. And they've done some studies even with bridge lights that flare at levels that are not recognizable during sleep, but they're flashing light at you. You don't recognize it as light, you just stay asleep. But that early light exposure was very helpful in teenagers, for example, who can't sleep. All they do is sleep. They go to bed late. They want to sleep until noon. Once they started the light exposures, their sleep changed by about 15 minutes each day, and it was done under control in a sleep lab where it was observed. So that's pretty interesting. And that there's teenagers with chronic illness, especially now. And so I think that's important with kids, and it's very important with adults as well. And it's certainly important in people with Parkinson's disease and dementia. When you get early morning light exposure, you're more apt to be awake and feel better. And when it gets early evening, turn the lights out, get things quieted down.
Interesting.
Yeah, which came first, dementia or sleep disorder? It's a circle. Literature is conflicting in that. Some people have sleep disorders and they start to become forgetful and appear to be getting dementia. A lot of people in their 50s will visit neurologists and say, I think I have early Alzheimer's disease. I can't remember anything. I can't focus. Other people start to become forgetful and don't focus and get lost and have more cognitive problems before they are found to have a sleep disorder. So some say yes, some say no, some say they're related, some say they don't. The literature's out there, but it's not a cohesive body of literature for sure. As I said, cognitive impairments occur in the normal population, especially in elderly people, as well as in people with dementia. The sleep disorders associated with dementia and with Parkinson's disease is largely going to be obstructive sleep apnea. It's not going to be restless leg syndrome. Nightmares are part of Parkinson's disease, but that's a separate entity as well. But that lack of oxygen during the night and frequent arousals because of the hypoxia, that can cause brain dysfunction and certainly problems in quality of life. Obstructive sleep apnea in and of itself, it primarily affects vigilance, how we function, and executive function, or the higher function, our ability to solve a problem and concentrate and pay attention. And of course, that's a big effect on driving and work functioning in people that are in their 50s and 60s and still working. Executive function, again, is the ability to solve problems, and that becomes moderately to severely impaired in people with sleep apnea.
Mm-hmm.
There's the answer. There's no established causal relationship. They're related, but there's not a causal relationship. there's no definite evidence that Alzheimer's disease, patients with Alzheimer's disease have a higher incidence of sleep apnea than the normal aging population. Aging, I mean postmenopausal women where estrogen and progesterone aren't around anymore, and that affects your airway. And as we age, things tend to drop. Our muscle structure is not as supportive even of our skin. Well, in people other than me, because I have, but the muscle structure is lax, and there's more people with obstructive sleep apnea in their 50s and 60s than there are in their 20s and 30s, although it affects people of all ages. The benefits of PAP therapy are interesting. PAP therapy meaning CPAP, APAP, BiPAP, positive airway pressure, where when a person is breathing in, there's gentle pressure, keeping everything away from the airway so that it can deliver oxygen. The benefits of PAP therapy in Alzheimer's are quite interesting. This study that I've put down here, the 2008 study, 3 weeks of true PAP therapy versus placebo, and they did not describe what the placebo was, and I'm not sure what a placebo would be for airway pressure. There was significant improvement in neuropsychological scores, especially in verbal learning and memory, and that's very interesting to me that that would have a big effect like that, and it was significant. There was improvement in executive functions, cognitive flexibility, and mental processing. And that's interesting because it's hard to solve a problem when you have dementia, and it's hard to solve a problem when you have sleep apnea. So that improved in patients with dementia on PAP therapy, and that's interesting. It's suggestive of treatment or diagnosis and treatment for certain in that population. It's also observed in cases of PAP therapy with people with obstructive sleep apnea in the normal aging population without dementia. I have several patients who complain of word finding. That's a big one. They can't find the right word for what it is that they're trying to express. You get caught in the middle of a sentence, and we all do it from time to time, but people with sleep apnea do it more often. We all can't remember where we put the keys here and there, but people with sleep apnea can't remember where they put their keys, and they'll struggle with little things like that and think it's part of normal aging. In most cases, it's not. The biggest limitation of PAP therapy in everyday practice is patient compliance, and it's quite low overall. I think in the 40s, 47% is what I remember reading about compliance with PAP therapy. I have a higher rate of compliance than 47. I'm at about 88% compliant, which is pretty good. And I just want to keep taking note of that. And I think one of the things we have to do with people with PAP therapy, especially with a caregiver for someone with Alzheimer's disease, dementia, Parkinson's disease, is proper education for them once they understand the value of the PAP therapy, not only for cognitive function, but in terms of high blood pressure and heart disease and the other problems that sleep apnea poses. When you educate someone and they understand it, the compliance is likely to be better. And a couple of studies that I read this morning, adding cognitive behavioral therapy to PAP therapy increased compliance. Wow. Hopefully the caregiver was included, because I think cognitive behavioral therapy would be hard for a person with dementia in the absence of treating that sleep disorder. Sundowning. This is a line that my husband once said, and I had to ask him to repeat it a couple of times so I could assimilate it, but take the time that it takes, and it takes less time. Find the cause for the sundowning. Is the person hungry, or are they thirsty? Do they need to use the washroom? Are they struggling with depression? That's a big one, I think, in the memory disorders. Boredom, because you can't attend to a task. You get fidgety and fussy, and the later in the day, the harder it gets. And your biological clock is obviously going to be affected if you're going to be up until late at night because you can't go to sleep. Melatonin production is going to be offset as well. And then when these people with sundowners, when it gets to the point where they're walking around all night, they start to sleep a lot during the day. And so they're not functioning as well as they could be and living some type of quality of life that they could be living because they have to sleep all day because they're up all night. I think this is a hard one to wrap your head around too, if you haven't been exposed to it.
Yeah.
What do we do? Some simple answers, of course. Once a person starts becoming agitated, you have to reduce the stimulation. It's no different, I think, than de-escalating a situation. When somebody gets agitated and they can't focus and they can't attend, or they're attending to something that's not related to what's happening over here, you have to be able to reduce that stimulation and bring that down as best that you can. And if that means that some people have to leave the room because it's too many people, or you need to remove the person from a room with a lot of people, or as a situation with a lot of people in the grocery store. Some people can get agitated and overwhelmed in a grocery line. And yeah, so I think de-escalation and reducing stimulation is probably one of the most important. Another thing, when they can't remember how to express something, snacks and drinks, I think, should be offered. Older people don't drink enough water. And I think that that's important to always have some snacks and some drinks available. May not be easy to say, I'm hungry. They may just feel agitated and not be able to communicate that. And relaxation in the evening is important. And that's important for people with memory disorders. And it's important for all of us. The brain needs to know that it's going to be time to go to sleep. The brain doesn't just shut off. And for some people, the brain doesn't shut off and they can't go to sleep because they have a plethora of probably worthless information that's swimming around in their brain and they can't shut it off. So relaxing, winding down, even a short walk after supper is sometimes helpful as well. Nighttime darkness, again, and although some people with memory disorders and sundowners become afraid because they feel that a shadow is a person, so they may need to have lights on if they become afraid. Morning exercise and bright light exposure, get them up and exercising, and walking is just a good exercise. Even just moving your arms in circles, something to burn some calories and wake up and realize that it's morning and this is daytime. Limit boredom. Once people get up and start walking around, there's nothing to do, they start to wring their hands and start to fret. As long as there's something to do and there's always someone to do it with, that's pretty nice. Daytime rest, short naps. Naps aren't really recommended in these disorders because you want to keep people awake as long as you can. The longer a person is awake, the more their body is going to want to sleep. So if we can keep them awake, or just take a short nap if they're tired, after 20 minutes, rouse them and tell them, let's go have something to drink and have some iced tea or something like that. Avoiding alcohol and caffeine later in the evening is kind of important as well. Heart disease, sleep apnea, and heart consequences can be prevented, absolutely. People with heart failure, what happens in sleep apnea? Do you want me to go through that, Patty? What happens?
Yeah, could you please?
Sure. When a person has sleep apnea, you fail to get enough oxygen because you're not breathing. You may have respiratory effort where you see some motion in somebody's chest or upper abdomen, but there's an obstruction above that, and so there's no air going to pass into the lungs. When that happens, your brain says, you know, you're not breathing enough, or you're holding your breath too long, and you're making every liter of blood low in oxygen. And that means that I'm not getting oxygen. And the brain, being a greedy organ, it wants 80% of the oxygen that we breathe. So when you make each liter of blood low in oxygen, the brain feels the action should be to push out more liters of blood. And it does it by sending a message to the blood vessels to constrict. When a vessel is squeezed, it's kind of like squeezing a hose or putting your finger over the end of the hose. The pressure becomes higher that pressure on the end of the hose. And the same thing happens with blood vessels, the pressure rises. So when you don't get enough oxygen, your blood pressure spikes during your sleep and you're not even aware of it. The heart likes to help with that, and it will start to beat faster and harder. If you picture your hand as blood pressure, there's resistance here when the heart is wanting to pump blood through there, and only part of that blood is going to get through. The rest of it is going to bounce back against the ventricle wall. And over time, the ventricle gets big and overworked. And so it becomes a bigger muscle because it's working much harder. When that happens after 20 or 30 years, the left ventricle, the workhorse, says, you know, I'm tired, I need a rest. And so the left ventricle will fail. And what was once a big pump pumping out blood is now just kind of flopping around. It's not functioning whatsoever. And all of that blood that should be pumped out from the left ventricle to supply the body backs up to where it came. And that's the congestion of congestive heart failure. And chronic heart failure, people live with congestive heart failure or CHF for years. They're managed on medications that help the heart muscle function, and they're managed on diuretics that keep the fluid levels stable so they don't hold a lot of fluid. They're going to hold a lot of fluid though, and they're going to have problems excuse me, with long-term diuretics. And sometimes they fail to respond to the diuretics and end up in the hospital because of that. They experience a lot of shortness of breath, and they can experience dizziness and syncope from the diuretics and from some of the drugs that help keep the heart muscle working. They can pass out. I know I had heart failure prior to my heart surgery last spring, and I went down once on post-op day 5. It happens from high-dose diuretics, and you know, people can lose their balance if they stand up too fast. So heart failure is one of those chronic illnesses that we need to really pay attention to. Pulmonary hypertension, that's a different sort of critter. It's if you think of high blood pressure in the pulmonary arteries and vasculature. And that's managed for the most part on medications and oxygen. I don't want to spend any time on pulmonary hypertension, but it kind of fits in a category with heart failure. Chronic atrial fibrillation, this is the bad boy. Chronic atrial fib results in dizziness and falls, and people pass out with atrial fib. They're often on anticoagulants, and they have a high risk of stroke. And so we have to pay attention to atrial fibrillation. And interestingly, I listened to a webinar that was a pulmonary critical care physician and a heart failure physician, and they were discussing atrial fibrillation and even palpitations in terms of sleep apnea. And anybody, the recommendation from them states any patient with atrial fibrillation and or palpitations should be tested for sleep apnea. And treatment for sleep apnea lessens ablation failures in cases of palpitations and atrial fibrillation. I think it was 80% who would convert back to atrial fib in 1 year with untreated sleep apnea, and 40% with treated sleep apnea. So that was pretty interesting how it reduces that. So those high blood pressure is a recommendation to the 9th Joint Commission on Hypertension said any patient with high blood pressure should be tested for sleep apnea. So the 3 recommendations, high blood pressure, atrial fib, palpitations, come out of the heart disease category in terms of sleep apnea. COPD, here we are. COPD has no cure. The bad thing with COPD, people can drop their oxygen and hold in carbon dioxide. That's a 0 on that slide too. I'm not sure why it looks like a small O rather than a 0. 16 million people in the United States alone with COPD. That's astronomical. Bad air quality, secondhand smoking, 75% of the patients with COPD have a history of smoking at some time in their life. Some of the problems with sleep in people with COPD takes a long time to fall asleep. They have a hard time breathing, even with oxygen. They might need to be propped up pretty high on pillows. They have orthopnea or difficulty breathing when they're lying flat in bed. So it's going to take them longer to fall asleep. And they have frequent awakenings during the night. And just about anybody that I've taken care of with COPD has a bad cough, a productive cough. They have a sense of panic with that cough sometimes. I think that's probably where you would see cough syncope, when a person is coughing so hard that they don't get air and they just pass out and they're still coughing. Yeah, that's pretty scary for people. But there's a lot of panic with COPD because you just can't breathe. You just can't breathe. And Patty, you probably can associate with that with treatments when you worked in the hospitals. The respiratory treatment was somewhat helpful for a period of time, and they had to have them every 4 to 6 hours.
Yeah.
It's very hard to breathe with COPD.
It's a scary feeling.
Yeah, it's very scary. And they experience oxygen desaturation or hypoxemia. And when they do that, sometimes they start fussing and picking around and wanting to do something. And when they hold carbon dioxide, their face turns a different color, turns a little bit reddish, and they get kind of drowsy. So there's a big difference. So you can always pick out what's happening with the COPD patient on their behavior and how they look. They experience air hunger. They tend to gulp air to get enough oxygen. And they have a lot of oxygen problems during the day. And so if that's happening when you're awake and you're trying to breathe normally, imagine what happens at night when we don't breathe normally. The low oxygen especially impacts Rem sleep, and that's where we dream, and that's where the brain has some work to do for itself. And it also causes, well, sleep deprivation is caused by a lot of things, but hypoxemia is one of the big ones. You just keep dropping your oxygen, you wake up each time. Keep dropping your oxygen, you wake up. Keep dropping oxygen, you wake up. So we're going to have sleep deprivation with COPD. And of course, sleep deprivation, we have trouble with focus and memory and judgment and daytime mood. This was interesting to me. Obstructive sleep apnea or COPD, is there overlap? There is an overlap, and those patients really do need to be treated, the patient that has COPD and obstructive sleep apnea. Any of the symptoms that any of us would feel with obstructive sleep apnea, COPD patients are going to feel that more than the average person does. So snoring, gasping, and choking during the night, people with sleep apnea do that. People with COPD are going to do that more because their lungs don't work as well as the average person. Morning headache. Some people say that occurs more with apneas and not breathing, causing carbon dioxide retention. And some people say it's from high blood pressure spikes. So at any rate, when there's a morning headache, it's probably something to consider. Am I sleeping well enough? We shouldn't be waking up with a headache. Excessive daytime sleepiness. Everybody gets a little sleepy, maybe after lunch. If you eat a big lunch, that's kind of characteristic. But when you can't sit at your computer and do your work, or your head woodpeckering in a meeting like this, or dropping your phone and you can't type. I know when I get tired, I can't type the right words. I keep making typos and I think, okay, that's it. I'm tired and I'm not going to do anymore. But excessive daytime sleepiness, the true definition is actually falling asleep at inopportune times. So if you're driving the car, that's a pretty inopportune time to fall asleep. If you're in a meeting, if you're in a conversation, if you're working with machinery or something, if you're a butcher, there are many occupations and scenarios where excessive daytime sleepiness is going to be a huge problem. In the average person, this is a factor. Falling asleep in a meeting, falling asleep in a movie, not being able to stay awake till 8 or 9 or 10 at night, just feeling so sleepy. Obesity is a factor. However, I was just thinking about two of my patients who have severe obstructive sleep apnea. One is 78 and rides a horse every day, maybe 6'1", 160 pounds. The other one is an avid hiker and weighs, I'm thinking maybe 130 pounds at 5'7". And they both are on very high pressures for severe sleep apnea. Excuse me. So it's not always just the obese person who's going to have it.
Yeah, I can attest to that. My sister has sleep apnea, and she's, you would see her and you're like, oh, she's a fit, young woman. But yeah, because anatomically she has that.
That's what I tell people. It has to do with the anatomy from here to here.
Mm-hmm.
If you have sleep apnea and you gain weight, it tends to get a little bit worse with increase in neck circumference. And one other thing that I saw come out of this American Academy of Sleep Medicine, a white paper came out and it referred to fat tongue syndrome, so that when a person gains weight, the posterior tongue becomes thicker. So I'm curious to see where that research goes.
Yeah, that's the first I've heard of that. That's interesting.
Yeah. And you see it when you look in a person's throat for a Friedman score or Mallampati modified Friedman, or Mallampati score, when their tongue tends to touch the uvula and the top of the soft palate to where you can't see if they have tonsils or they don't. Pulmonary, okay, so reduced daytime oxygen saturation. It's interesting, in primary care, a saturation of 95, 96 is fine in a young, otherwise healthy person. In sleep medicine, I look at that and think the person may have what's called a hypopneic disorder, where they breathe shallow all the time. During the day, they may catch themselves yawning or sighing quite a bit, but 95, 96 to me means there's probably a shallow breathing disorder. But it doesn't mean that the person's ill. Again, primary care, it's fine. Increased daytime carbon dioxide. You'd only find that when you're doing blood gases, and in some terms, sleep studies. For some cases, to get an in-lab sleep study, we have to have blood gases. We have to be able to document the arterial CO2. So that would be the only way that you'd find that. Pulmonary hypertension, definitely they should be tested for sleep apnea. Right-sided heart failure, yes. Polycythemia, absolutely. Opioid and hypnotic prescription use. Opioids, people tend to say that it depresses the respiratory system, and I always would say, what does that really mean? What it means is that it alters a person's response to low oxygen or elevated carbon dioxide. It changes the way that you respond to it. And that results in central apneas, which are different than obstructive apneas. It's where your brain doesn't tell your lungs to take a breath. But I'm not sure what depressing the respiratory system really means, but that's actually what happens. History of type 2 diabetes, heart failure, or stroke. People with COPD that have any of those conditions also should be tested. What else can we do? The primary goals of therapy, of course, is to reduce carbon dioxide and increase the level of oxygen that people are getting. And PAP therapy does that. We can always bleed in oxygen as we need to, or we can add in breaths depending on the type of ventilation we have to use. Sometimes people have Bipap therapy, and that may be more effective in COPD, where the pressure is a little higher when they breathe in and lower when they breathe out. And if we have to add breaths in there, we can add up to 10 or 20 breaths if we need to. If people are only breathing a few times a minute, we can add whatever we need. When they have chest symptoms, cough and shortness of breath and air hunger, what can we do to help them with a cough? Not very much. And people with COPD, when you have a productive cough, that needs to happen. The harsh, dry cough that people like me have from allergies, that doesn't need to happen. It's a waste of energy. But when you have COPD and you're coughing up mucus, you really do need to get that out of your lungs. GERD symptoms, the changes in thoracic pressure, and I wanted to pop on that and just say that what happens when you have acid reflux and sleep apnea, whether you have COPD or not, once you're asleep and you're not breathing, but you have respiratory effort, but you're obstructed, so your chest is moving, your abdomen's moving, and the pressures in your chest abdomen area are changing, but air is not getting through. That causes the stomach to release some acid, and it ends up being all the way up your esophagus and can bother your vocal cords. And that's a pretty nasty cough in the night and a sensation of choking. And some people actually aspirate from that. So what do we do for that? Gaviscon was recommended by an ear, nose, and throat doctor who happens to be right an awful lot of the time. And taking 2 tablets of Gaviscon actually does act like a plug. I tried it one night, and for me, I had to wash it down with water because it felt like it was getting larger when I was trying to swallow it. And I'm not sure if that's the case, but I washed it down with water, and I didn't have any acid reflux at night. I don't usually, but I did have some heartburn that night, so I tried it. But anything like that that can reduce acid reflux at night, if you're going to have some reflux, at least modify the acid so that it doesn't affect your esophagus or your vocal cords. Cancer, the statistics are alarming. 30 to 75% of newly diagnosed or recently treated cancer patients. That's double the rate of the general population. A lot of it is insomnia. This was interesting. There were so many citations and studies that, you know, when you start to read and you wander off on different directions, that's what I did with this. It was very interesting. But one study compared cancer patients with psychiatric patients and with controls that are just volunteer people that have neither cancer nor psychiatric disorder. 62% of them report moderate to severe sleep disturbance, 53% of the depressed patients, and only 30% of the volunteers. So 62% is twice that of the normal population right there. And very few studies investigated the disturbances among advanced cancer patients who are maybe heading toward hospice. Most common complaints, difficulty falling asleep, difficulty staying asleep, and certainly not feeling rested. If you have any of the insomnias and you're up half the time, you're not going to feel rested when you get up. And interestingly, almost 20% of the patients reported having poor sleep habits before they were even diagnosed with cancer. I want to just say something about cancer. Most of the studies are done in females with breast cancer rather than a big circle of cancer patients with different types of cancers. I didn't find much in head and neck cancer. I thought that would be interesting, but there's so many different kinds of cancers and different types of tumors that most of the studies are focusing on women with breast cancers.
Interesting.
So a reported sleep disorder is what you complain of to your provider, but what you record in a sleep study is different than that. And it's interesting that the most common sleep disorder was limb movement disorders, and PLMD means periodic limb movement disorder. I maybe could have put periodic limb movements of sleep versus disorder, but that was the most common recorded sleep disturbance. And this was interesting too. Spielman was an academic, and his 3-factor model of insomnia was interesting to me. Predisposing factors that increase vulnerability to insomnia, hyperarousability, people with startle reflex that's maybe higher than other people. They're higher, like a lot of adrenaline, like close to anxiety maybe. Female gender, aging, and personal family history of insomnia. It does tend to run in families. Precipitating factors, what triggers the onset of sleep disturbances? Of course, cancer itself, just getting the diagnosis of cancer is very, very unsettling. And naturally, one would just think, being diagnosed with cancer, of course, you're not going to sleep very well. Cancer-related emotional impact and functional loss, cancer-related treatments, pain and delirium that can happen in cancers, some cancers, those are precipitating factors. And perpetuating factors, what makes it keep happening? Maladaptive sleep behaviors and faulty beliefs and attitudes about sleep. Maladaptive sleep behaviors include poor sleep hygiene, and that doesn't mean showering before bed. Sleep hygiene refers to a set of behaviors rather than cleanliness. Well, it's nice if you have a shower, but that's not sleep hygiene. So establishing a bedtime routine is a big thing. Going to bed at the same time every day, getting up at the same time, even if you don't have to establish that so that your brain knows, when I go in here and I lie down, that means sleep, and I've already prepared for it. There are people that fall asleep on the couch, and when they get up, they have to go upstairs, and then they want to wash their face and brush their teeth before bed. Well, then they're awake. So what do you do about that? Wash your face and brush your teeth right after supper. So if you fall asleep on the couch, all you have to do is climb up the stairs and put your carcass in bed. Once you start doing things after you've had a little bit of sleep, you're going to wake up. And faulty beliefs and attitudes about sleep. I don't need sleep. It's not a big deal. I'm fine. A lot of those bad beliefs are prominent, and it's going to perpetuate your insomnia. And I read another quote that I wanted to inject right there. Insomnia is like a bully. The more attention you pay to it, the bigger the bully gets.
I like that. Yeah.
Yeah. And sleep isn't going to happen unless you're sleepy. So if you have anxiety with adrenaline, cortisol, and everything running around and keeping you amped up, you're not sleepy. You may be exhausted, but you're not sleepy. And sleep doesn't happen unless you're sleepy. This is an interesting slide. Hypnotics or sleeping pills are the most commonly prescribed medications to cancer patients who can't sleep. Hypnotics, we'll go through the statistics first. 48% of the total prescriptions with sleep as the provider's stated reason for the prescription in 85% of the 814 total prescriptions analyzed. So 48% in 85% of the 814 were hypnotics. That's a lot. Another study found 44% of approximately 400 prescriptions in over 200 consecutive cancer clinic patients were written for hypnotic medications. And it's just really not the answer, but we'll get there. Compared with rates published 10 years ago, there's a 30% increase in the prescription of psychotropic medications in cancer patients with a greater range of reasons. And some of the reasons may be depression, anxiety, insomnia, among others, but that's a lot of medications increased. Avoid antihistamines, that's a big one. A lot of people are prescribed hydroxyzine. The other name for hydroxyzine is Atarax, and back in my early day as a nurse in Canada, we used Atarax and Demerol as a pre-op medication. Prior to surgery, we gave them an IM injection of Atarax and Demerol. And the idea was, now we use Tylenol or acetaminophen pre-op before you have surgery. Back then you used an opiate, which was Demerol, but Atarax or hydroxyzine was used to dry up secretions pre-op. So antihistamines aren't always going to make a person drowsy for sure, but a lot of people are prescribed hydroxyzine, and some people it helps and some people it doesn't. Sleeping pills, most of us have a certain bias against sleeping pills because a lot of them are habit forming, cause physical dependence, and even if they're not working, I've had patients come in who have been on Ambien for 10 years, longer than 10 years. Their body is dependent on it, but it's no longer helping them sleep, and it no longer helps people sleep after about 3 or 4 weeks. It's great for episodic insomnia that's a response to a tragic event. If you lose a parent or even a dog, I mean, when you have episodic insomnia in response to an event, it's okay to use Ambien for a little while until you can regulate your sleep again. But for 10 years, not a good thing. In older people, the benzodiazepine sleeping pills are not a good choice either. One of them has a half-life of 40 hours, I think. The other one that's commonly used, temazepam, has a half-life of 8 to 24 hours. And that means after 8 to 24 hours, 50% of that medication is still circulating. So the next night you take another temazepam, and now you have 100% of that dose and 50% of the dose from the night before, and so on and so forth. So it's cumulative. So the benzodiazepines are not a good choice in elderly people. The shorter acting benzos are okay, and a half a milligram of clonazepam might be okay as well. You use that in sleepwalking and some of the REM acting out disorders. But sleeping pills or sleepers or hypnotics aren't really the best choice. Good, better, best. CBT for insomnia is very effective. It's more effective than pharmacotherapy, than giving drugs for sleep. Some of the literature, CBT is as effective as prescriptions right from the start. And the added benefit is that learning from cognitive behavioral therapy lasts a lot longer than the effects of a medication over time. Like the Ambience, it's not going to be helping you after a few weeks, but people keep taking them because the doctor says to take them because it's helping with their sleep, but it's not. This was interesting, effects of group cognitive therapy on breast cancer patients, improvements in sleep efficiency, and that was measured by PSG. Total sleep time, mood, and cognitive aspects were quality measures that were done on a survey. But isn't that wonderful that a person with breast cancer, not only a support group for breast cancer, but cognitive behavioral therapy helping their sleep. Without sleep, we just don't function well. We don't produce the cytokines like we should. And in cancer, immunotherapy is very important. So you want them to have better blood cell counts and better cytokine production. So that's really interesting to me how helpful the group CBT was for people with breast cancer.
Absolutely.
Yeah, and it's nice to see that a lot of hypnotic drug use was also decreased after therapy. Excuse me, chronic pain. Add insomnia to chronic pain. Not a good scene. We've all had chronic pain from time to time. I'm sure there isn't a person who hasn't had something that hurt for a period of time longer than 6 weeks. Start good habits from the beginning. When someone goes to you and tells you that they have pain, make sure you ask about sleep. Make sure you ask. People don't bring it up. Pain interrupts sleep so often, and especially in older people who have fragile sleep as it is. Older people have more pain, chronic pain, than younger people, just as a function of aging. If you ever watch the show, My Feet Are Killing Me, people whose toes are crossed right over top of the other ones, that arthritis in small bones, that's so painful, and that wakes people up. When they have a lot of pain, it's okay to give them something for pain before sleep. Sleep's so important that whatever you can do to help a person sleep, do it. Relaxing distraction, that's helpful in some people with chronic pain, and other people just don't even want to discuss it. Pain medicine at bedtime, yes. A sleep schedule, yes. If you keep staying up late because you're hurting, people get afraid to go to bed because it's going to hurt worse. If I lie on my right side, my right shoulder hurts. If I turn to my left side, my hip hurts. My knees hurt if they're straight. My knees hurt if they're bent. My small bones, my toes, my fingers are so painful. Then they need some pain medicine before bed. Pain and more pain. The majority of older adults in the US have chronic pain. That's right. Getting enough exercise is a key role in pain management. People don't have to be running marathons, 10-minute walks here and there, 5-minute walks add up during the day to what may be exercise for an older person. Catastrophizing, there's a lot of studies speaking to catastrophizing pain. It's so bad. My knees are so painful. Wah, wah. Winding yourself up about the pain, then you're going to be less active. The next day, you're going to hurt more because you were sedentary. I know when I sit in this chair all day doing telemedicine and working at home, every time I stand up, I'm like, oh, my knee, that hurt. And I think for older people who have chronic pain, this is terrible to just let them sit. The more active a person can be, the better for them. Even just little shoulder rolls like that, we don't even do that enough during the day, even though we tend to sit like this typing and doing things. If you just take a minute to unclench your jaw, push your shoulders down and back, it feels so much better. And we should be encouraging older people to do that. To test or not to test, this was one of the questions that Patty gave me. How do I know when I need a sleep test? If you have an insomnia, sleep testing is not indicated. Sleep tests tell us if we're awake or if we're asleep and in which stage of sleep we're in. But it doesn't say, Patty stayed awake for 20 minutes between 2 and 3 thinking about what to make for lunch tomorrow. We don't ever get the subjective cause for not sleeping. And commercial insurance will not pay for a sleep study for insomnia, and there's really no point in doing it. That's a diagnosis you make by history and discussion. Excuse me. A person complaining of snoring, they should be tested. Their airway is partially obstructed. I believe the airway's open between 30 and 35% only when you're snoring. So yes, that test would be important for sure. Nighttime coughing, choking, and gasping for air, absolutely time for a sleep test. Daytime sleepiness, need a test. Don't want you driving behind me when you're falling asleep at the wheel. And snoring, this one I just should back up and say that this is going to be a complaint from your bed partner rather than a subjective observation. You're not aware of snoring while you're asleep. But if your bed partner is saying you're snoring and you're having trouble breathing, that means you need a sleep test. Trust your bed partner on that one. So when the bed partner complains of excessive moving, when you have a brain arousal, you're not awake. Your brain wakes up without telling you to wake up in response to the lack of oxygen. And oftentimes you're going to move around in response to that. Some people twitch, have twitches during sleep rather than when you're falling asleep. That's indicative. So when you're moving around, kicking around in your bed, your covers look like World War III, that's a common one. When you're snoring and when you're having abnormal breathing, you need the test. When you have chest pain and shortness of breath when you wake up, you need a sleep test. When you have difficulty breathing when you're lying flat, you need a test. Figure out why. Frequent awakenings at night, you need a test. Again, it doesn't tell you why you're waking up, but there's a reason why, and a lot of times it's low oxygen. Restless legs in the evening or when you're falling asleep needs a test. The medications that we use for restless leg syndrome are the ones we use for Parkinson's disease, dopamine, adrenergics, and agonists. And so when you want to use those kind of medications, you want to quantify the restless leg syndrome. More to test or not to test. When you have difficulty concentrating during the day, forgetfulness, and daytime fatigue, get a sleep test. at least rule it out. If you have a sleep disorder, you need to know. Knowledge is power, and you're going to get better faster when you have the knowledge. When you wake up with a dry mouth or a sore, dry throat, you need a sleep test. That a lot of times is from snoring. High blood pressure and sleepiness, test. Palpitations, test. Palpitations oftentimes stop when you treat the obstructive sleep apnea. Atrial fibrillation, each patient with atrial fib should be tested for sleep apnea. Night sweats with daytime sleepiness, test. Decreased libido, not in and of itself, but with sleepiness, absolutely. Sleep affects hormones, and testosterone is one of those hormones that's affected. So yes, test that person. And there's two examples of sleepiness. These are my German Shepherds, and we lost Tanny, the one on the red blanket, in June, and just lost little Quebecy at age 7 a few weeks ago. But they were good sleepers, and how she fell asleep like that, I don't know. But I guess if you're that tired, you can. Questions from anybody? Comments?
Is that the end of the slides, Terry?
Yep.
Okay, I'm going to go ahead and stop sharing that. So I just wanted to kind of have you elaborate just a little bit too, because a lot of our members in the group, a lot of them are owners of what we call a residential assisted living home. So they're caregivers and homeowners, and they tend to cater more towards the senior community. And in that type of a role, when you have somebody that's in the home, how would you suggest for them to go about, getting sleep testing for their residents? So let's say that the family agrees that yes, they snore, yes, they have these indications. What would be the next step?
It depends on their insurance, if they need to have a primary care referral or not. If they need a primary care referral, then the thing to do would be to start there. If they don't, they can just call us directly.
Okay, perfect. And if there's any question, what they could do is call you, and then you could direct them once you view the insurance to determine if they need that mobile plan. Okay.
Yeah, most people know if they need a primary care referral, but if you have some dementia, you're probably not going to know, but yeah, they can call and David can check on that for sure. And the nice thing that we do is in-home sleep testing, so the person doesn't have to leave the facility other than for their appointment, and we can do a telemedicine follow-up so they don't need to leave too.
I'm curious if there have been any studies, or if they've read anything specifically, Terry, about people with dementia and their ability to wear the therapy at night. I know you touched upon it briefly, where the caregiver needs to be educated as well, but can you elaborate on that just a little bit, or maybe give them some tips?
Yeah, it's very difficult in people with memory disorders to keep it on, but I think the frequent checks are going to help with that too. If they're in a assisted living facility, if their door's open and the caregiver that's working at night can see that the equipment is off, help them put it back on.
Yeah,
just keep an eye on that. And I think people have to do that with one another anyway, but that's probably one of the observations a person should make as a nighttime caregiver.
Okay, perfect. And there's so many different options too when it comes to the type of masks that they can work closely with you, and that's what you would help them with, correct? Trying to find the best fit and the best.
Yeah, one thing to consider, if a person is a mouth breather at night, they're going to need some type of full face mask, whether it's the triangle F20 that fits over your nose and sits on the bridge of your nose and underneath your lip, or the less invasive one that sits like this, has holes for your nostrils and then a little cup that goes around your mouth. That's the new F30. That's a nice mask too. The F30i has a hose that comes out of the top of your head rather than in the front, and the air comes down the sides in silicone tubing. Some people like that, and some people don't like that because it's kind of wide on your face rather than just a strap.
Oh, okay.
And there's pillows for people that are nose breathers. They're just little nubs that set at the edge of your nostrils and they get sucked up there when the pressure starts. And there's some with just a little tray that goes underneath. All kinds of different options.
Absolutely. And with our, we also have a lot of individuals that have chronic illness as well. And so you would definitely recommend that if they're experiencing those symptoms or have those types of disease process going on that you suggested or that you shared with us, that they should definitely be tested.
Yes.
Yeah.
Yeah. I mean, your quality of life is already severely affected with with a chronic illness. Whatever we can do to make the daytime better, and making sleep better makes daytime better for sure. So that's a helpful for people with chronic illness.
And I did read, oh, sorry. Go ahead.
The other thing I want to say about keeping the PAP on at night, if the mask isn't comfortable, nobody's going to keep it on. So we keep trying and trying and trying until we find the right fit. Medicare allows one change out of the mask in the first 30 days. So that's not very much. I don't like this one, so I'm going to try that one. But I find that you're really a nose breather and you don't need a full face mask, even though you think you might be a mouth breather and tried that. So I always tell patients, you know, you go to the primary care office and you get samples of medications and see how that helps with your acid reflux or your blood pressure. When you come to me, I give you a mask to try. You know, you fit it for somebody and keep trying until you have one. The reps keep us in stock enough that we can do that once or twice more until we find the right fit.
Oh, that's really nice. That's really nice. And then do you have a tool that you could share with us? And I know you do, and I'm asking you this in a question, but I know that you've got like little questionnaires that you could share with some of our homes and some of our mobile providers that go out to the homes and see these residents, that they can kind of use as a checklist to see if this could be beneficial for their patient or their resident.
Yeah, for sure.
Okay.
I have one for, well, the Epworth and stop bang is pretty good for sleep apnea. Is it good in chronic? Is the Epworth good in chronic illness? Not always, because when you're sequestered at home, you're not going to be falling asleep in a theater or at church because you don't go to the theater or to church. So the Epworth isn't as sensitive in chronic illness, but the stop bang is pretty sensitive. And there's some questionnaires that I have for acid reflux and restless leg, but those are pretty obvious. I think the Epworth and stop bang are probably going to be the most valuable. So sure, I have one too where they're both on the same page. I'm happy to get that to you.
That'd be perfect. Yeah. And then we'll make it available on the group page.
Yeah, for sure.
Yeah, that's fantastic. I so appreciate you taking time out of your day today. You gave us so much really good information. And I'm just going to let people know that if they want to ask questions, they can always comment. I know you're following along with us in the group. So again, Terry, thank you so much. Is there anything that you want to share that maybe you haven't shared? I know you've.
No, I can't think of anything. Sleep when you're sleepy. Limit your naps to 20 minutes. Sleep is important.
So important.
Give it the time that it deserves.
Thank you, Terry, so much.
For sure. Thank you, Patty, for asking me.
Absolutely.
Bye for now.